Kia ora koutou. Welcome to the Skylight webinar on trauma-informed care. I'm Dr. Chris Bowden from Victoria University, and today we're going to be talking about what is trauma-informed care, how can we implement a trauma-informed approach in our services, and what would that look like in terms of our commitment and responsibilities to supporting people who've experienced trauma. I want to start today by talking about two cases that are going to highlight the importance of trauma-informed care. The first case is Pete. Pete is a young man who lost his best friend to suicide. He went to a local counselling service to get some support and help. During his intake and assessment, he disclosed to a counsellor that he was having difficulties sleeping, he was having flashbacks, he was depressed, and that he had been drinking and recently lost his job. He talked about having difficulty dealing with the emotions and the impact of suicide, and how he was also struggling with the ripple effect that this had had on his life. In particular, he was about to be evicted from his flat and was needing some housing assistance. Pete's situation is not unlike many people's situations, where they have experienced significant trauma in their life and have complex needs. The problem with Pete was he came to a counselling service that was not trauma-informed. And what happened to him had a significant impact on his access and use of that support service. When he told the counsellor about his experience of trauma, that counsellor, because he or she did not have a significant background in trauma-informed care, pretty much minimised what he told her in relation to his trauma. She didn't see it, or he didn't see it as trauma. And that counsellor basically offered Pete very little choice in terms of what support he could access. She told him that his only option was to join a local peer teen support group and encouraged him to go along and talk about his experience with other peers. The second case is a little bit different. This case relates to Kaya, a 38-year-old case manager working in a drug and alcohol counselling service. Kaya sees many clients who come into her service looking for support and help around drugs and alcohol, but they often have many other mental health issues as well, and housing issues and other relational issues like Pete. She helps them unpack some of those issues, find support, provides advocacy, and helps them make sense of what's going on for them. Kaya's mum and dad both had alcohol-related disorders, so she had her own lived experience of this issue. She loved her job, she works 60 hours a week, has difficulty leaving her job and work at work, takes a lot of it home, worries a lot about her clients and what's going to be happening for them over the week. And some of her clients actually started to feel that she was being a little bit overprotective and a little bit over-involved with her client's life. Recently, Kai had been having nightmares and flashbacks and being preoccupied with thinking about what was going on for her different clients. She's never experienced trauma herself directly, but it was clear to her manager and to those around her that listening to the stories of trauma in her clients was starting to have an effect on her and her job. They noted that she'd become defensive, judgmental at work, and a little bit withdrawn from others. Kaya's supervisor was concerned that she might be experiencing what we call secondary traumatic stress. Now, both Pete and Kaya would have a very different experience if they were working and being supported in trauma-informed care services. Kaya, if she had been in a trauma-informed service, would have been looked after and taken care of in relation to her secondary stress. that workplace would have had things in place to assess staff, to support staff, and to provide ongoing help for staff experiencing secondary stress. Pete, too, if he had been in a counselling service that was trauma-informed, would have had a very different experience. I hope that these two cases highlight the importance of trauma-informed care. We need services to work from and be organised around a trauma-informed approach. When they are not, we have both clients and staff who can be put at risk and who can experience re-traumatisation and stress. Many different services that provide support for people who've experienced trauma vary along a continuum of care. Some will be what we call trauma aware. So they will have staff and policies and practices in place that indicate that they are aware that some of their clients may be experiencing trauma, but their staff may have limited knowledge and there may be limited access to trauma-specific support. If we move a little bit down that continuum, we can have services that are sensitive to trauma. So these are services that do have a trauma lens to their work, do have a different approach. They might offer some basic training and have some policies in place and some practices in place to support people, both clients and staff who have experienced trauma. The goal is right down the end there, trauma-informed care, or what we call trauma-responsive services. These are services that have trauma fully integrated in all aspects of service delivery, from the policies and the mission statements right down to what happens to people when they walk in the front door. So the organisation, the working environment, the support that's provided, and all of the processes and policies and practices are based around a trauma-informed approach. That's the gold standard. That's what we're aiming for. And what I want to recognise is that services that are out there, and those that may be watching this webinar will be able to maybe see where they are positioned on this continuum. The webinar today is about helping people who are working in those organisations and services understand a little bit more about what a trauma-informed approach might look like, what are the principles behind it, and how you might be able to help organise and rejig your service so that it becomes more trauma-informed. There are some very good reasons why we should address trauma, and through a trauma-informed approach. First of all, trauma is complex. Trauma requires a coordinated, multi-pronged, multi-agency approach that includes education and awareness. We need services to be educated and their staff to be trained in trauma. It's very easy for services who are set up to help people who have experienced trauma to re-traumatise them. They do this inadvertently and they do it unknowingly. And for many people who experience these services, this is their one shot of getting support. And if they don't get supported in a way that is helpful and effective and sensitive to what they're going through, they may turn and walk away as Pete did. If we want our trauma-based services to be effective, to be high quality, to be responsive to the community, we need them to be trauma-informed. There are some other reasons why we should be moving towards a trauma-informed approach. A great deal of trauma goes unrecognised in our community. We have a lot of people who use welfare, mental health, drug and alcohol, education services who come with trauma. If services are not aware of that trauma and aren't set up in order to screen and identify and support people with that trauma, it's going to be very difficult for them to work towards recovery. As I said before, some organisations re-traumatise their clients, their patients and their residents, and staff who have experienced trauma, in Kaya's case. We also know that trauma impacts the way that people access services. it makes it difficult for people to reach out for help. It makes it difficult for people to engage with support workers. And so trauma-informed services are inviting and responsive and safe. And so those services are more accessible to people who have experienced trauma. And what we know from the research is that trauma-informed services often refer to and use trauma-specific treatments or utilize community agencies who provide that treatment. So what it means is that when they recognize trauma in clients and patients and residents, they can actually refer them on to people who can treat that trauma and help them towards recovery. That brings us to trauma-specific treatment. Now, not all agencies and support services provide treatment facilities or programs. These are often clinical-based programs that are tailored to address specific elements of trauma. Other trauma-informed agencies might provide care, education, advocacy, information, psychoeducation for friends and family, and other forms of support, but they may not provide treatment. It's important that people who have experienced trauma also have access to trauma-specific treatments, and we'll come back to this later in the webinar. So what does it mean to be trauma-informed? What does trauma-informed look like? What is it based on? What are the principles or the key ideas behind this kind of approach? Well, we're lucky because for a long time, other countries have been working on moving their services and organisations towards being trauma-informed. So here in New Zealand, we don't have to start from scratch. We've got some good guidelines and some good principles that have already been developed that can help us move towards being trauma-informed. SAMHSA has developed the 4 R's of trauma. And in these 4 R's, we see an approach that makes services become sensitive to trauma, aware of trauma, and responsive to trauma. The first R is realise. Trauma-informed services, systems, and organisations realise the impact and widespread effect that trauma can have on individuals, their families and whānau, and their wider community. So they're looking for it, they're prepared for it, and they're willing to engage, not just with individual clients, but with that person's whānau group and community. And trauma-informed services realise that people who have experienced trauma, their behaviour, their mental health problems, their substance abuse, these are coping strategies. These are seen as attempts of these people to deal with the trauma that has been experienced in their life. So they don't see this as problematic behaviour, they see it as attempts to cope. The second R is recognise. Trauma-informed services recognise the signs and symptoms of trauma in people who access those services. So they know what to look for. They're aware of it. They have staff who are trained to look out for these signs and symptoms in people who front up for help. So staff have a thorough understanding of trauma. They see trauma not just as a neurological or psychological or biological issue, but they also understand that trauma is embedded in a context. What trauma looks like for women, what trauma looks like for minority cultures, what trauma looks for young people and older people is very different. So staff in trauma-informed services understand the different ways that trauma looks. And they understand how those contexts of history and culture and politics and gender shape how people experience trauma and the impact that it might have on them being able to access support. The third R is respond. Trauma-informed services respond and organise all aspects of their service based on a trauma-informed approach. That means from top to bottom, from the policies and the mission statement right down to rules and regulations about safety, policies and practices that everyday staff implement. So they are responsive, they are organised, and it is pervasive throughout the service. This is not a tack-on or an add-on. This principle is something that organises the whole service. The fourth R and final R is resist. Trauma-informed services actively resist re-traumatising their clients, patients and residents and staff. They are aware that working in a space with trauma can re-trigger people who have experienced trauma, asking them questions about their trauma, assessing that trauma and working with that trauma can create problems, not just for the clients but for staff as well. And so trauma-informed services work very hard not to re-traumatise clients and staff. This brings us to SAMS' 6 principles. So that was the 4 R's. We also have 6 key principles that trauma-informed services are based on. The first one is safety. I'm going to look at these in a little bit more depth in a minute. The first one is safety, and that principle says we need to provide a service and agency and support that has a psychological and physically safe environment, not just for clients but for staff as well. The second principle is trustworthiness and transparency. Trauma-informed services are very transparent, very clear about why they do what they do, and communicate with people very clearly about processes. That enhances predictability and safety for clients and patients and residents. The third principle is peer support. Trauma-informed services provide people who've experienced trauma with access to peer support. One of the key aspects of recovery is being able to work with and walk alongside other people who are recovering from trauma. The fourth principle is collaboration and mutuality. This principle is about staff and clients working together with families to provide the best care possible. It's about working to goals that individuals, families, and the service providers come together and negotiate. This is not about what the service wants to provide, it's about what clients and families need. The fifth principle is about empowerment, voice, and choice. People who've experienced trauma often experience disempowerment. They have been silenced and they have been marginalised. So this principle is about making sure that your service enables people to have a voice, that we listen to them, and that we provide resources and resiliency and enable them to make choices and decisions. The sixth principle is difference and diversity, and I touched on this before. This principle is about recognising that people heal and deal with trauma in different ways, and that we need to be respectful of cultural, historical, gender and other differences between people. Trauma-informed services do not provide a one-size-fits-all type of service. They provide a service that is responsive to the needs of individuals and groups as well as whole communities. Along with those 6 principles comes a bunch of commitments. If people are going to try to change their practice or their organisation or the way that they deliver their service, they need to make a series of commitments. And these commitments are not easy. The first commitment is about power and control. Trauma-informed services are about sharing power and control. So we need to be thinking about, do our services and policies serve us or serve the people that we're trying to help? How is power and control shared between staff, clients, and families? It's also about doing with and not doing to people. So this means making a commitment to working alongside and collaborating with people who've experienced trauma rather than us doing interventions which take over and mean that we are doing things to people. It's about consent, it's about getting permission, and it's about being safe. The explaining what, why, and how, again, promotes transparency. People who've experienced trauma need to go at a pace that is suited to them and need to understand the steps that are being taken. We need to offer real choices and flexibility. People need to be able to engage with the service when and where they feel safe and comfortable. That means if clients don't show for 3 appointments, we don't ditch them and knock them off the books. That means having a more responsive and accepting policy. It also means understanding the fight, flight, or freeze responses in clients. So staff who work in trauma-informed services understand what trauma looks like in the people that come and are able to respond and support people through dealing with triggers and responses. And the last one, which I think is almost the most important, is that trauma-informed services work from strengths. It's not about fixing people, and it's not about focusing on the problems that they experience solely. It's about working towards solutions and recovery, helping those people identify their strengths, their resources, their pathway back to recovery. That's some pretty heavy commitments to make. And you can see from this that working in a trauma-informed way means shifting your mindset and possibly changing the way that your culture and organisation works. There are some more commitments, and I've highlighted these because I think they're really important as well. We need to work in a non-violent way with people who have experienced trauma, and that means not using seclusion, not using restraint, and not using coercion. That can be a significant challenge for people working in psychiatric fields. We need to promote emotional intelligence, so we need to help clients develop skills for them to be able to regulate their emotions and be self-aware. Trauma-informed services also work on social learning, so they're interested in helping people develop skills that enable them to integrate back into society and work and live as a fully participating member of a community. Because we know that people who've experienced trauma often withdraw socially from their community. Fourth commitment is about open communication. We need to be really clear about what we expect and help people develop healthy communication and conflict management skills. When they feel frustrated, when they feel unlistened to, when they feel upset or frustrated with the way the system works, we need to teach them how they can respond and give us feedback without resorting to violence or aggression. We've talked a little bit about social responsibility and democracy, and that is related to helping people get back into society and to build skills that will enable them to be fully functioning within that community. And the last one is growth and change. So trauma-informed services are focused on helping people grow and change through their trauma in such ways that they can learn to integrate that experience and live with it and manage it going forward. Now, you might be thinking this sounds like a tall order, a pretty tricky and difficult task. How do we move from being trauma-aware to trauma-sensitive to trauma-informed? Well, the first thing we can do is use some of the tools that have been developed by others who have gone through this process. Again, we don't have to reinvent the wheel. SAMHSA has produced tools, and other organisations have created tools that will help us move from being trauma-aware to trauma-informed. These tools tend to have some different components. They have a self-assessment component, so that people can look at their own practice as an individual and do a bit of a check and see where they're at in relation to being trauma-informed. There are also components to these tools that can be used by whole organisations to be looked at across the organisation, from frontline staff right up to top management. And basically these tools have a series of questions and a series of boxes that enable people to go through a process at their pace with support to identify where they're at on that continuum and what they might need to work on. So on the screen you can see there are 10 ingredients for a trauma-informed care approach. Now this is one representation of what a trauma-informed care approach looks like. There are others that are out there, but I find this one particularly useful because it's an infographic which makes it easier to remember and see what it's all about. So I'm going to go through each of these ingredients and just spend a little bit of time talking about what they mean in relation to each of these ingredients. This is also what we can think of as benchmarks for measuring whether our service is trauma-informed. So it's something we can work towards, but it's also a benchmark we can use later on to think about, are we doing this stuff? So let's look at the first one, which is lead and communicate. So in order for a trauma-informed approach to work, we need good governance and good leadership. This is not something that one person can do within an organisation. It needs to be supported by senior staff, leaders and management, and there needs to be a clear commitment that comes from them around resourcing, funding, time and space for staff to not only do that self-assessment, but also to work towards changing the way that they deliver services. So we need some buy-in from the top, and we need good leadership from those people at the top. And often the first thing that people start with in relation to working towards this is looking at their mission statement or their value statements and going, can we see the principles that we talked about earlier in that mission statement? Do we value those things? Can we see them, and can our clients, our patients and our residents also see them? We also need really clear policies and position statements that show that this organisation or service values those principles. And that needs to be communicated clearly to staff and to the people who access that service. We need to be using those principles of trauma-informed care in our strategic planning. So when we're thinking about what we deliver and how we deliver it, we need to be thinking about those principles. A trauma-informed approach needs to be hardwired, and this takes time. So most organisations who are working towards this will struggle a little bit because it takes time to change people's ideas and perspectives and practice. But basically, we need everybody to be working from this perspective. So from the person who answers the phone, to the cleaners, to the drivers, to the support workers, the volunteers, the clinical staff, and the senior management, we need them all to be on board with this approach if it is going to work. There also needs to be a key point of responsibility. So there needs to be somebody in the organisation who can be a trauma champion, somebody who can help people, motivate people in relation to changing their practice. There needs to be a good plan, an implementation plan. So after you do your self-assessment and you figure out where you are in an organisation, you need to start thinking about what are the next steps. And these guys suggest setting up a working group or a working party in your organisation to take that on board. So we need a trauma champion, we need buy-in from the top, and we also need a working group who are going to be dedicated to making sure this gets rolled out. Being trauma-informed and having that leadership means that we need to prioritise some things. And in particular, that means routine screening for trauma, not just in our clients, but also in our staff, having culturally responsive principles of practice, using best evidence approaches in terms of treatment and care and support, creating a positive peer environment, and making sure that we, again, go back to those principles of voice and choice, making sure that the people that we're trying to look after and support have a voice and have choice. And that comes from strong leadership. If we have to adapt policies, we might need to make some changes in relation to the language that policies are written in. People who've experienced trauma like to be called different things. And we need to make sure that that's reflected in our policies and our written information and our services. Some like to be called survivors. Some like to be called clients. Some like to be called people who have experienced trauma. So we need to be careful about the language that we use and use people-first language. And we need to make sure that our policies protect those people, ensure that they give informed consent, and that they have a clear understanding of grievance processes and feedback processes. So those policies need to be very clearly written and available for clients and residents and patients to be able to review. I put up some questions there because I think they help prompt people to think about why do we have the policies that we have. For example, if you're looking at your policies and you're thinking, is this something that's trauma-informed or not, you might want to ask yourself, why does this policy exist? Who does it serve? Who does it help? If it doesn't help your clients, if it doesn't help the people that you're trying to support, maybe it's not an appropriate policy. If it hinders control and empowerment, maybe it's not a good policy to have. If it doesn't allow people to give feedback and change that policy, if we don't involve our people who've experienced trauma in policy development, maybe we need to rethink that process as well. So it's good to have consumer input, to have community input when redeveloping policies. The second ingredient is engaging and involving clients, and I just mentioned this. So this ingredient is about saying we need to promote voice and choice. And that means that our clients, our patients and our residents should have input into policy development, but not just policies. They should have input into the kinds of programs that are offered, the services that are offered, even the design of the facility itself. So what does the waiting room look like? What kind of resources are in there? People need to have input into that. Does this space reflect their needs and their identities? And we need to ensure that there are processes in place so that the people that we work with can give confidential feedback to the service and agency. How often do you, as an agency or organisation, enable people to do an anonymous survey to give you feedback on what you provide? It's a good starting point. The third ingredient is training staff. Training and supporting. At a baseline, we need staff, all staff, to have a basic understanding of trauma. Other staff may need more advanced training, but all staff need to know how to work and support people who've experienced trauma in a way that makes them feel safe and welcomed and trustworthy. We need staff to know about informed consent. We need staff to know about professional and personal boundaries, because we know that people who've experienced trauma often struggle with personal boundaries. We need staff who are good at crisis management. So they need to be trained to be able to respond to people who are in extreme distress. They need to be able to spot people who are suicidal. They need to be able to know what to do to calm people down, to de-escalate, to calm people, to provide a sense of safety. And we tend to think about giving training and staff development to our clinical people and the people who run programs, when in actual fact, it is our frontline staff that spend more time with clients. They are the ones that are on the phone. They are the ones that are talking to them in the waiting room. They are the ones that are waiting with them and chatting with them and supporting them while they're filling out the paperwork. And they will have more regular contact than often some of the clinical people and the people running programs. So my point is, we need to think carefully about who we're training and make sure that everyone in that organisation and service has some degree of training around this and that it's appropriate to their role. These are some of the things that we need or could provide in order to upskill our staff. Some general training around trauma and how it affects people, maybe a little bit of training around what trauma-specific services are available in the community. That would require people to know what those services are and upskill them. Anti-violence groups, groups for refugees and services and programs for Māori and specific gender support groups. Knowing who they are and what they do in the community and what they have to offer is really important. So we need to make sure that staff have some training around those services that exist. Some specific topics that might be useful to upskill staff with include the links between trauma and mental health and substance abuse. What are the connections between those? Some stuff on cultural competency. What does trauma look like in different cultural groups? What does trauma look like in different genders? how we can help clients develop communication and relationship skills, and how we can minimize re-traumatizing people that come to our service. Vicarious traumatization. What does it look like? Can staff identify in themselves and in their colleagues? And can they support staff who are experiencing stress and burnout and compassion fatigue? These are all things that you might like to consider in terms of training. The fourth ingredient is to create a safe and supportive environment. Now, this goes well and beyond creating a safe physical environment. This is about creating a safe physical and psychological environment. So we need to make sure that the service, the building, the organisation, where people come into is well lit, it's safe, it's secure, it's clearly marked, that the exits are well indicated, that toilets and other private areas are well indicated, that calming music is played, that the artwork in the waiting room reflects the community's needs and identities, and that people feel welcome and respected when they come into that space. We also need to make sure that staff maintain healthy boundaries and that they're working from a principle of kindness, collaboration, respect and recovery. These things are going to make people feel safe and make people feel that they can trust the service to meet their needs. Here are some examples of some key essentials in terms of providing safety. How we welcome our clients, patients and residents makes a big difference. Whether or not people are introduced to staff members within a service, so that they're not all of a sudden being pushed into an office with someone that they don't know and don't have a relationship with. That they're taken on a tour in the premises so that they know where the exits are, so if they become overwhelmed or distressed, they can leave without causing a scene. Information. We need to display clearly the information about the service, what you offer, how you offer it, what they can expect from you, but also a copy of rules and regulations. Maybe you have some rules and policies around no alcohol on the premises, whether or not this is a child-friendly space or not. So this information needs to be clearly displayed in order for people to feel that they are in a safe and secure environment. The fifth ingredient is preventing secondary trauma in staff. So we're interested in not just preventing secondary traumatization or re-traumatization in clients and patients, but also preventing secondary trauma in staff. There are many people who work in trauma-related services, whether they're volunteer or paid staff, who come with their own trauma backgrounds, as we saw in Kaya's case at the start. Some of that trauma will be disclosed or not disclosed. And what we need to be aware of is that if you're working from a trauma-informed approach, that your service or agency makes it clear that they are there to support staff who have experienced trauma. And that means that they may have to screen and assess for trauma in staff when they're hiring staff, but also in existing staff. We need to be mindful that when working with clients, that can re-trigger our own trauma. It means that trauma-informed services need to provide regular ongoing supervision for staff to make sure that staff have good self-care plans and safety plans themselves, not just for clients, but for staff members as well. And if you're a trauma-informed organisation, you will regularly seek information and feedback from your staff about their own well-being and their own experiences in the organisation. And you will make improvements based on those surveys. The sixth ingredient is having an informed workforce. So again, this is kind of connected to upskilling and training our staff, but we also need to make sure that we're really clear when hiring people that these principles are important. And they should be reflected in the job descriptions, they should be reflected in the hiring policies and HR processes, they should be included in the interviews that we have of staff. We should ask them about their approach to working with trauma. You could even go as far as saying if you're going to work in a trauma-informed service that we need to prioritise hiring staff who have qualifications in trauma. certificates, diplomas, degrees, as well as relevant work experience. Or that you might encourage your staff to work towards some of those qualifications and support them in their professional development. The seventh ingredient in a trauma-informed service is involving clients, patients, and residents in treatment programs. Now, this might sound a little strange. Don't the experts know what's best? Doesn't the evidence tell us what works in terms of treatment efficacy and effectiveness? Well, to a degree that is true. But if we really want to work from a trauma-informed approach, we will make sure that people who come to our services for treatment and support have real choice. So we need to be able to provide them with a number of options in terms of support and how that's delivered. And that may mean referring them on to those trauma-specific services that I talked about. If you can't meet their needs, you need to be able to refer them on to other services that you know are safe and effective. But offering people choice also means enabling them to have power and control over the pace of support. So whether or not they come and see you weekly or fortnightly or monthly, they need to have these choices. They also need opportunities to review their goals and to develop those goals in conjunction with their whānau and family and partners. It means that we need to explain the potential benefits and limitations of the services that we offer. So in Pete's case, that counsellor should have said to him, you know, we can offer you this peer support group, but that might not fit your purposes. These are the pros and cons of that particular support group. What about this option or that option instead? We also need to ensure that we provide people with an opportunity to have input into their own safety plans. So they need to be able to identify what triggers them, what supports them, and what is helpful and unhelpful, and to construct that plan in conjunction with their support worker. The eighth ingredient is screening for trauma. Now this one I can't emphasize enough. If we don't ask about it, we won't know about it. And so universal screening is highly recommended, but we have to do it carefully. What that means is when people come in to a service or agency for support, we often do what we call an intake assessment, which is collecting a little bit of information about who they are and what their needs are. If we don't ask about trauma in that initial intake, it may come out much later and it may hinder their support and recovery plan. So we need to ask about it, and it's quite simple. There are lots of examples of checklists and tools that agencies and services can use to screen for trauma during that intake. Screening for trauma is different to doing an assessment. Clinical assessments of trauma are done by trained clinical professionals. The screening could be done by somebody who's sitting on the front desk, who's had a little bit of training around the tool and how to manage it. And what we need to screen for is trauma-related symptoms, adverse childhood experiences, past and present mental health disorders, all of the things that you see there on the screen. But you'll also see that we need to screen for social support, coping styles, and the strengths and resiliency of that person. So it's not all deficits focused. The other thing is we need to be really clear and to communicate with people why we are screening. Why are we asking them about possible trauma in their lives? And to me, that signals to that person that we are committed to working with trauma in a trauma-informed way. If we don't ask, it's almost like we don't care. Here are some examples of some screening tools that are freely available on the internet. And as you can see, there are tools there. These are all valid, reliable, fully tested, scientifically based, theoretically sound tools. We've got tools there for children and adolescents. We've got ones that screen for trauma, ones that screen for adverse events. We've got adult ones, adult versions for people over the age of 18. And these, again, are fairly short, between 10, 15 and 40 questions. Tick box, really simple. Have you experienced any of the following? If so, is it still affecting you? And so it's relatively simple and easy for people to fill out, and it doesn't ask them to dredge into that trauma and talk about it in an in-depth way. That is done much later after we have put in a safety plan for them and during an assessment. So screening is really simply about identifying who might have some trauma in their background and whether or not it's influencing and affecting their everyday life. How we do that screening is really important. Self-administered checklists are good rather than a face-to-face interview. People need privacy and people need some time to think about their responses, and they need to feel safe. They need to be conducted in a private, confidential space. The limits of confidentiality also need to be really clearly explained to people. There are some conditions and times when confidentiality should and must be broken. And those situations are often when people disclose that they are at risk of harming themselves or harming others. Screening and intake should also include questions about their current needs, their resources, we touched on this, their history of other problems, but also their cultural background and strengths. How might they like to be supported in relation to their culture, gender, and background? The other thing we need to be wary of is that people vary in their literacy ability and their ability to make sense of what the questions are asking them. So sometimes you may need to offer an interpreter or somebody who can explain those questions to that person, but it should not be a family member and it should not be somebody who doesn't have a background in trauma. They need to have someone who they can trust and who has a background in managing distress. As I said before, we're not just about screening for our clients. We also need to be screening for staff in relation to secondary traumatic stress. Up here on the screen, I put a table which kind of explains the difference between burnout and secondary traumatic stress. And on the left here, you can see the SAMHSA tool has a simple tool in their document which looks at compassion, satisfaction, burnout, and secondary traumatic stress. It's about 3 pages. Again, it's a tick box kind of checklist, and it's something that staff can actually tick off themselves and see where they're at in relation to how burnt out are they feeling, do they have any secondary traumatic stress, and are they satisfied in doing their job, or do they have compassion fatigue? Burnout and secondary traumatic stress are common amongst people who work with people with trauma, more common than what people think. Burnout tends to be related more to a lack of resourcing and mismanagement and maybe caseload and stress. People who experience burnout often leave their jobs. They quit. And we need to be ensuring the safety of our workforce, but also protecting that knowledge and expertise and institutional wisdom and experience that comes with that workforce. Secondary traumatic stress is a little bit different to burnout. Secondary traumatic stress usually results from people listening to or being exposed to the trauma stories in others. So this is what Kaya might have been experiencing in relation to her clients. Listening to the stories of other addicts and people with substance abuse problems and relating to that and not being able to set clear boundaries. And so what we see in workers who experience secondary traumatic stress is that they often start to exhibit the same symptoms that their clients have. They start to show signs of trauma. They start to become fatigued, don't care about their job anymore, may disassociate or disengage from people. They become desensitized to the work that they do. And again, a trauma-informed service or agency would take this very seriously and make sure that they put things in place to ensure staff safety. The 9th ingredient is that we need to be able to use and refer clients, patients, and residents to trauma-specific treatment services. I mentioned this right at the start, and I gave you a definition of what these are. But we need to actually understand where they are and what they do, and be really clear in communicating that to clients when they're making choices, so that they can actually make an informed choice. Trauma-informed services will not send a client or a patient or a resident to another service that they don't know anything about. They will not risk that service re-traumatizing that person. They will make sure that that person knows what that service does, how they provide it, who they're going to meet, how often they're going to meet, and what they can expect when going down to that other service. So this requires agencies to have really good, strong connections with other service providers and to collaborate with them. And this means that they need to work collaboratively. Now, this raises some issues, and I'm just about to touch on some of the challenges of doing this kind of work and working from this approach. And one of them is about information sharing between services. We need to make sure that when we refer people to services and programs and other interventions that are trauma specific, that they are evidence-based. Here are some examples of some adult and child-focused models. This is what I would be looking out for if I was referring someone to another service. Do they offer the option of trauma-focused CBT? Do they offer prolonged exposure therapy or EMDR? Have they got child-focused models of working with people that involve both working with the child and their parent and family? Do they offer models and support that focuses on attachment, self-regulation, and emotional and relational issues? So it would be remiss not to investigate and not to understand what kinds of treatment people offer and what the boundaries around those services are before referring. The last ingredient for a trauma-informed approach is engaging partners in cross-sector collaboration. And I've touched on this already. If we're going to support people who've experienced trauma and they do have complex needs, we need to work together in a collaborative way. That often means sharing information. That often means trying to understand each other. And it also might mean sharing resources. So trauma-informed services will work collaboratively with other services, and they'll almost form a community of trauma-informed services, so a network. And what they will do is they will work really hard to facilitate conversations, to provide opportunities for staff to connect, to talk with each other, and to make sure that people work together with a really clear understanding of what the boundaries are and what people do in different services and agencies. And where you get this happening, you get a much more coordinated, comprehensive, and effective response from services. Everything we do that's related to silo-based models of support goes against this principle. There's one other ingredient that I wanted to add that wasn't on that infographic, and this is the ingredient of monitoring and evaluation. So if we're going to work from a trauma-informed approach, we need to also build into that approach a process of monitoring and evaluating our practice, policies, and programs. So that means that we need to take time out on a regular basis to reflect on our work. What are we doing? What is our clients' experiences? What are our experiences of this work? What kind of research can we gather or data can we collect that might inform our development of our service, but also reinforce and motivate staff to keep doing what they're doing? Data is really important. Data is really important for motivating people to help them see the progress that they're making. If we see higher patient and client satisfaction, if we see less problems in the waiting room, if we see people being able to access other services more quickly, that kind of data can really inspire staff to continue working on this journey towards being trauma-informed. So information and feedback is a very, very important part of this process and approach. I want to finish up by talking briefly about some of the key challenges to this. This work is not easy. The people, the researchers, the people who have written about trauma-informed approaches overseas, who have been involved in services who have worked towards this model and worked towards this goal, have all explained and explored and discussed some of the challenges that they met along the way. Now, I think these challenges are really important because we can learn from these experiences so that we don't make the same mistakes ourselves. The first one is that people need time to change. You cannot go into your organisation and demand a quick fix, a quick change to being trauma-informed. This is going to take time. It's going to take leaders, and it's going to take buy-in. It's also going to be challenging to find people, good trainers, good educators, who can come in and train your staff and help you upskill, or even provide some guidance and support while you're working out your new policies and procedures. So we need to be able to be mindful that it could be difficult to find those support people. There are challenges that come with people being honest about their own practice. A lot of organisations and services like to tick boxes and say, yes, we're doing all of these things, but they're not really being honest about what they do. And so honesty is a big challenge for this. Are we being honest about our own practice? Are we being honest about our collective practice and service? Developing a strategic plan can be difficult at the best of times, but it can be really difficult if staff are resistant and fixed in their positions and roles and don't see why they need to become trauma-informed. They just do this bit or that bit. This is someone else's job. So that can be really difficult. We also need to make sure that those principles, particularly the one around self-care, and this is something that I've been working on with staff at the university, is that we build self-care into performance reviews. So we make sure that we signal to staff that it's really important that they look after themselves and that they seek support and help when they need it. And that's not stigmatizing. That's actually about them being responsive to their own needs and self-aware. And I would like to see that in performance reviews where people say, well, what have you done this year to look after yourself in terms of your own safety and well-being? The other part is sustaining trauma-informed change. So what happens in these organisations who are working towards this is that they see some minor improvements and then the pedal goes off the gas and the change doesn't continue. It loses momentum. Somebody moves on to something else, or there's stress or other challenges that come into play. So sustaining that momentum can be easier when you have a larger working group or team driving this. If you're working in a group towards improving your service delivery and organisation, how often you meet, who's involved in that working group, making sure you pick the right people, that you provide the rest of the staff in the organisation with updates and information about what your working group is working on and the progress that you're making. All of that can help sustain that momentum. Gaining outside facilitation, technical assistance, again, I said that was a bit of a challenge. It can be, but we know that there are lots of organisations who are already doing this. And what I would suggest is that people hook up with an agency or service that's already going through this process and maybe partner up with them and share their learnings. I think one of the big challenges for people who come together to think about becoming trauma-informed is that there are so many other priorities that are taxing them. And they need to be thinking about, is this our biggest priority right now? Maybe funding, maybe dealing with other issues is something that's on staff's mind at the moment, and it's going to make it difficult to get staff to work towards this goal. But in actual fact, I hope that I've kind of convinced you that if you do this, you're going to have better outcomes. You're going to have better outcomes for your clients and your staff. And so to me, it would be a priority, a major priority. I think the other challenge is, I've said that there are some tools out there that you can use. There are some checklists and screening tools and different instruments that people have developed. Finding something that fits your organisation might be a bit of a challenge. And don't be afraid to adapt it, to take those tools, to sit down with your group and organisation and staff and say, how do we make this work for us? How do we do this at a pace that we can handle? How can we make sure that we do this properly and, to make sure that those tools are helpful tools? Bryson did a bit of a study about some of the factors that really help people move towards a trauma-informed approach. So we've talked about some of the challenges, but these are the things that really make a difference. These are the things that they found helped organisations move towards that trauma-informed approach. The first one was leadership. Really important. That was the starting point. If you've got good leadership at the beginning, the rest of it seems to flow quite well. Staff training and support was the second thing. Helping staff understand why they have to change reduces resistance. Making sure that you amplify the voices of clients, patients, and residents and families. This was critical in order to create organisational change. It's very hard to argue with the voices of the people that you're trying to support. If their voices and their perspectives are seen and heard, staff can't say, well, this might or might not work, right? The fourth ingredient is having an outcome orientation. And again, I can't emphasise this strongly enough, that if we provide staff with data, that the changes that they're making are actually having a real impact on the clients and people that they're trying to support, that's going to be a huge motivational factor. When people see improvements in the people that they're trying to support and that data is being used. I don't know about you, but I've filled out lots and lots of different questionnaires in my professional life. Never seen any of the results of those questionnaires, don't know what happened to that data, don't know whether it made any difference at all. So making sure that if you're going to collect data from staff and from clients and people who use the service, that it is then reported and used in ways that are transparent. And the last thing that they showed made a real big difference was aligning policy practice with trauma-informed care. When you've got the policy and you've got the practice and they both align with those principles, that's when you know you're making a difference. How do you know? How are you going to know that you're making a difference? How are you going to know that you're progressing towards this trauma-informed approach? Well, benchmarks and standards can help. And SAMHSA, the Department of Mental Health and partners, and some of those organisational tools that I said that you could use to do a self-assessment also have benchmarks and standards. So that in their tables they have, this is what trauma-informed might look like. And then you can see whether or not you're moving towards those benchmarks. And again, it's about progress. It's not about doing this overnight, it's about working towards those goals and tackling each piece at a time. This is my last slide. I wanted to conclude on this. I think trauma-informed approach is really important. It's really important if we want to do things right. It's important if we want to do the right help at the right time in the right way, and that's what Skylight stands for. If we're going to help organisations move towards a trauma-informed approach to change their system, that need to understand that this has benefits. What are the payoffs? Why should you change? Well, you should change because it's going to benefit the people you're trying to help. It's also going to benefit the staff in your organisation. It's also going to bring those two groups together. It's going to enable them to collaborate and to develop a service which is far more responsive, far more effective. And to me, this is really exciting. When you work together with the people that you're trying to support, you can create something pretty amazing. Thank you for watching. Look out on the Skylight Hub for more webinars on this series and others.